Hello everyone, this is Dr. Govind Rai Ghar. In this video, we will discuss about anti-dyslipidemic drugs. Now, most of the people they say hypolipidemic drugs that is a misnomer you can say because we do not want to decrease all the lipids. All are not bad. We know HDL is a good cholesterol. So the right word is anti-dyslipidemic drugs. Okay. So what is the outline of the chapter? We will discuss about main drugs which are statins, fibrates, bile acid binding agents, ezetimibe, niacin, and then some of the new drugs for decreasing the serum lipids. Okay, so we'll starting with the most important hypolipidemic drugs. We say they are statins. So first we'll try to understand how they work. This is our liver. Liver is the major organ where cholesterol is synthesized. So how cholesterol is synthesized? Cholesterol is synthesized from the compound known as HMG-CoA. HMG-CoA, it is converted into mevalonate by the rate limiting enzyme which is HMG-CoA reductase. HMG-CoA reductase is the rate limiting enzyme in formation of cholesterol, and then this mevalonate will help in formation of cholesterol. Okay, so statins, they work by inhibiting HMG-CoA reductase. Statins inhibit HMG-CoA reductase. So when they inhibit HMG-CoA reductase, there will be less formation of cholesterol in the liver. But we know statins are hypolipidemic. Emic means in the blood. So they decrease cholesterol in the blood. They have decreased cholesterol in the liver. But how it will decrease in the blood? Now what is important thing is liver is not able to make cholesterol. But liver require cholesterol. Liver has to do so many things. Liver has to form bile acids. It has to form vitamin D. It has to form steroid hormones. So everything require cholesterol. So liver is not able to form cholesterol. But liver is a very efficient worker. He says that I am not able to form cholesterol, okay, but I will do my work. But for his work, he require cholesterol. So what it will do? Now the liver will increase the expression of LDL receptors on its surface. On the surface of liver, now LDL receptors amount increase. Now what LDL receptor do? They will take up the cholesterol from the blood. So whatever cholesterol is present in the blood, it is taken up by the LDL receptors. So when the cholesterol from the blood goes into the liver, that leads to hypolipidemic effect. Yeah. So how the statins work? They inhibit HMG-CoA reductase that stop the formation of cholesterol in the liver. That lead to upregulation of LDL receptors on the liver, and that take cholesterol from the blood. Okay. That is the complete mechanism. Okay. Now what are the drugs which are statins? The name of these will end with statin. Examples like atorvastatin, rosuvastatin, pravastatin, serivastatin, simvastatin, lovastatin, and pitavastatin. So some of the important statins name I have mentioned. In the exam, the question is asked, all of the following drugs are HMG-CoA reductase inhibitors except, and in the option they give all 4 statins. So that means there are some statins, means whose name end with the statin, but they are not HMG-CoA reductase inhibitors. And what are those statins? Those are cilastatin. Cilastatin. We have pentostatin. Pentostatin. And we have a hormone called as somatostatin. So that means any drug which end with the statin is not necessarily a statin. So we need to find out something else. And what we find is all the drugs which end with the statin is okay. But before the statin we need to see, and it is common thing VA. So statins are statins only if they are vastatins. If they are not vastatin, they are not statin. Like this is lastatin, this is tostatin. So statins are statins only if they are vastatin. Like cilastatin is given with imipenem to inhibit its breakdown. Pentostatin is an anti-cancer drug. Somatostatin is a hormone. So statin is a statin only if it is vastatin. Okay, so that is important about the nomenclature. Now coming to important points. The first and the most important point to remember is statins have maximum LDL cholesterol lowering potential. So among the oral drugs, statins have maximum reduction in LDL cholesterol. It can decrease other lipids also. It can decrease triglyceride, VLDL also, but maximum decrease in LDL cholesterol is caused by statins. So other beneficial effects are also there. Means they will decrease the VLDL, they will decrease the total cholesterol, they will decrease the triglyceride, as well as they increase HDL. But maximum decrease in LDL cholesterol is their main forte. Okay. Now, second important thing, most of these statins, they are given in the evening or late night. Why we are giving them at evening or late night? Because the HMG-CoA reductase, it has maximum activity at night. So we want that the concentration of statins is maximum when the enzyme is working maximally. Okay, so they are giving in evening or at night, except the first two statins, that is atorvastatin and rosuvastatin. These are very long acting statins. Rosuvastatin is the longest acting. Both of them are long acting. These can be given at any time of the day because they are very long acting. Okay? So except rosuva and atorvastatin, all other statins should be given at night because HMG-CoA reductase is working maximally at night. Okay. Now, third important thing about statins to remember is their side effects. Side effects of statins are very, very important to understand. And what are these side effects? The most important side effect of statins is myopathy. Myopathy. Statins can cause myopathy. So there should be regular monitoring of the enzyme called as creatine phosphokinase CPK. If the levels of CPK is elevated, means it is signifying the myopathy. Now, what is special point about myopathy to remember? Statin induced myopathy, the risk is increased by certain situations. And what are those situations? If a person is receiving fibrates also, in particular the fibrate which is most responsible is gemfibrozil. Gemfibrozil also cause myopathy. So when we combine it with statins, there is high risk of myopathy. Second important thing is if we give them with enzyme inhibitors. Enzyme inhibitors, they will inhibit the metabolism of statins. So their plasma concentration increase that can lead to myopathy. And which are the important enzyme inhibitors we should avoid? These include clarithromycin and itraconazole. So if we give statins with clarithromycin or itraconazole, there is more risk of myopathy. So these three interactions are very important to remember. Okay. So first side effect is myopathy. Then apart from myopathy, statins can cause liver damage. Statins can cause hepatotoxicity. Third important side effect is they increase the risk of diabetes mellitus. Hyperglycemia can be seen. But here is important point to remember, although statins increase blood sugar, but still they are recommended in diabetic patients because diabetic patients have high risk of developing atherosclerosis and complications of atherosclerosis. So we have to control dyslipidemia. So we will use statins, but we will adjust the dose of anti-diabetic drugs. Okay? So three major side effects you need to remember: myopathy, hepatotoxicity, and increased risk of diabetes mellitus. Next important thing to remember is interactions of statins with meals. Mostly we say that the food decrease the absorption of the drug. But in case of statins, food increase the absorption of drug. So absorption of statins is increased by food. That is important to remember. So that is about the side effects and interactions of statins. Now, statins have one very important action which is known as pleiotropic effects. pleiotropic effects. Now, what do we mean by pleiotropic effect is, it has been found that statins benefit the cardiovascular system, not only by controlling the lipids, but by many other mechanisms. Clear? So, all other mechanisms which benefit the cardiovascular system are called pleiotropic actions. Clear? So, statins have two type of actions. One, it control dyslipidemia, and second, it has other actions to benefit the heart. So all other actions are called pleiotropic actions. And what are the pleiotropic action? So you can remember like pleiotropic action, P-L-E-I-O tropic, pleiotropic action. So what are the pleiotropic actions of statins? PL means plaque stabilization. Statins make the plaque stable. Remember, we know that the extension of plaque increases in size after rupture. When the plaque ruptures, so more of the substances accumulate that increase the size of plaque. So they will stabilize the plaque, prevent its rupture. So when it is not rupturing, it will not further increase. Okay. Then second, they decrease endothelial dysfunction. We know endothelium, which is producing nitric oxide and many other important mediators. So these mediators are released less, in that lead to cardiovascular disease. So that dysfunction is reduced by statins. Then statins have anti-inflammatory activity. So they can decrease inflammation. They can decrease oxidative stress also. Oxidative stress, free radical damage is not there. Then they have decreased risk of thrombosis. Decreased risk of thrombosis. Tro means thrombosis. So all these are called pleiotropic effects of statins. So what is important in the exam question is asked, which of the following is not a pleiotropic effect of statins? So what are the options given? It cause plaque stabilization. It cause decrease endothelial dysfunction. It cause decrease in oxidative stress, and it cause decrease in LDL cholesterol. And we never look at decrease of LDL cholesterol because we think that it decreases LDL cholesterol. But that is the answer here, because although it decreases LDL cholesterol, but this is not pleiotropic effect. It is the main effect. So statins, the main effect is to decrease lipids, but pleiotropic are all other actions. Okay. So statins have beneficial effect on cardiovascular system. Okay. Now, most of these statins, they are metabolized by CYP3A4. Statins are mainly metabolized by CYP3A4, but you need to remember two important exceptions. One exception is pravastatin, and second is rosuvastatin. Their metabolism via CYP3A4 is quite less. Now, regarding pravastatin, you need to remember three things. One, its metabolism is not by CYP3A4. Second, it do not interact with meals. So meals do not increase the absorption of pravastatins. And third, it has minimum risk of myopathy. So 3 M's are less in pravastatin. Metabolism by CYP3A4 is less, interaction with meals is less, and risk of myopathy is less. That is with pravastatin. Okay. Now, regarding the individual statins, some important points if we are able to find. We discussed atorvastatin and rosuvastatin are very long acting statins. They can be given at any time of the day. Pravastatin, we discussed 3 M's just now. What are the 3 M's? One, interaction with meals is less. Second, metabolism by CYP is less. And third, less myopathy. Then simvastatin and lovastatin, important to remember, these drugs have maximum CNS penetration. Maximum CNS penetration is with lovastatin and simvastatin. So you can remember in Hindi, sim means Simran, lova means love. तो सिमरन का जो प्यार है, सिमरन का जो लव है, वो सर चढ़ के बोलता है. सर चढ़ के बोलना मीन्स CNS में घुस जाना. Clear? तो maximum CNS penetration is with simvastatin and lovastatin. Okay, so that is about the first group of anti-dyslipidemic drugs. They are statins, the most important drugs. Okay, now second group of drug is intestinal cholesterol absorption inhibitors. Intestinal cholesterol absorption inhibitor. So what happens is, this is our GIT. So in the diet, obviously we will eat some cholesterol. So the cholesterol which is present in the diet, it need to be absorbed and go to blood. And this is with the help of a compound called as Niemann-Pick-like 1C1 protein. So this is a protein NPL1C1, Niemann-Pick-like 1C1 protein, which help in absorption of cholesterol. So if we inhibit this protein, cholesterol will not be absorbed, and the drug doing this is ezetimibe. So ezetimibe, it inhibit the intestinal absorption of cholesterol. So when cholesterol is not absorbed, what will happen? Cholesterol is not absorbed. So liver will not get enough cholesterol. So when there is not enough cholesterol in the liver, liver require cholesterol. So how it will get cholesterol? Now it will increase the number of LDL receptor on its surface. So that will take up the cholesterol from the blood. Okay. So cholesterol from the blood go into liver, that leads to hypolipidemia or treatment of dyslipidemia. Now what is important to understand, when we give statins, liver is not able to make cholesterol. Okay? So when liver is not able to make cholesterol, what will happen? Compensatory body want cholesterol, so it increase the intestinal absorption of cholesterol. Okay? So statins effect will be reduced after some time because more is absorbed from the GIT. Second thing, when we give ezetimibe, intestine is not able to absorb cholesterol. Cholesterol cannot come from the intestine. So what will happen? There is upper regulation of cholesterol in the liver. So liver will start forming more cholesterol. HMG-CoA reductase is induced. So more cholesterol is formed. So compensatory mechanisms are there that will limit the use of these drugs. But if we combine the two, if we give ezetimibe with statin, so these compensatory mechanism is blocked. So now there is more effect on the dyslipidemia. So statins can be combined with ezetimibe, so that will benefit the two drugs. Dyslipidemia can be treated better. Okay. Then third, we have a group of drugs called as fibrates. Examples like clofibrate, fenofibrate, gemfibrozil, bezafibrate. So the drug names contain fibro or fibrate are fibrate group of drugs. Now how these drugs work is, they stimulate a receptor called as PPAR alpha. They stimulate a receptor called PPAR alpha, and when this receptor is stimulated, it increases the production of lipoprotein lipase. So when the lipoprotein lipase is more, it will break triglycerides. So statins, that's fibrates, that's why have maximum triglyceride lowering potential. Maximum triglyceride lowering potential is present with the fibrates. Okay. Now in the fibrates, important things to remember, fibrates increase the risk of myopathy. In particular, you need to remember is gemfibrozil. So we should avoid the combination of gemfibrozil with statins. Other fibrates have lesser risk, but they can cause. Now, second important thing to remember, fibrates, they increase the risk of gallstones. Gallstone risk, cholelithiasis risk is increased by fibrates. Okay, so that is important about fibrates. Then we have drug called as bile acid binding agents. Bile acid binding agents, the short form we can write is BABA. So first of all, we will try to understand how they work. So this is our GIT. We have stomach, intestine, this is duodenum, these are the intestines. Then we have blood here, this is blood here. We have liver here, liver. In the liver we have gallbladder here, and gallbladder will drain the bile through bile duct into the duodenum. This normal anatomy we know. So now what happens is we have eaten some cholesterol in the diet. So we have eaten cholesterol in the diet. So in the diet, the dietary cholesterol is coming here. Dietary cholesterol has come here. Now the gallbladder, it will secrete bile acids. So bile acids are produced in the liver, sent to the gallbladder. So bile acids will come here. Bile acid through the bile duct will come here. So what is the function of bile acid is? Bile acids will bind to this cholesterol. Bile acids will bind to this cholesterol. When the bile acid bind to the cholesterol, so this cholesterol is absorbed. So this cholesterol is absorbed. So bile acid with the cholesterol, they reach the blood. So now what happens in the blood, bile acid is dissociated from the cholesterol, and now this cholesterol can be utilized in the blood. So cholesterol is utilized. And now the bile acids which are present, they will be secreted in the liver, in the bile. So it is secreted in the bile. So through the bile, they will come again in the GIT. Again, they will bind another cholesterol and that will absorb. Again, the cholesterol is sent here and bile acids are again secreted into the gallbladder. So this will keep on happening. So what is happening from the intestine? The substance is going into blood, into the liver, again into the intestine. So the substance, bile acids are circulating between the intestine and the liver, and again they are utilizing. So that means one bile acid is bringing many molecules of cholesterol inside. So this is known as enterohepatic cycling. Entero means intestine, hepatic means liver. So there is cycling in the liver, in the intestine, in the liver, in the intestine. This is happening. Okay. So what is the advantage? One bile acid can bring many molecules of cholesterol inside. Okay? So you can assume that this is a situation similar to like bile acid is a taxi driver. So what happens? Bile acid is a taxi driver. It has parked its taxi in the duodenum. So whenever cholesterol comes, cholesterol is the passenger. It will sit in the taxi. So now the bile acid and cholesterol, that means the taxi and taxi driver along with the passenger, they come into the destination. Blood is the destination. So at the destination, passenger is removed. And now the bile acid, that means taxi, it will again be sent into the station. So airport, it again park there. So again it will bring another passenger, it will park there again. So this will keep on happening. Okay? So this is the normal enterohepatic cycling. Now what happens when we give BABA, bile acid binding agent? As the name says, we give them orally. So when we give them orally, so this taxi driver which is parking the taxi here, bile acid binding agent, the name says they will bind to bile acid. So now we have given them orally. So bile acid binding agent are coming here. So they bind to the taxi driver. They bind to the taxi driver and this combination cannot be absorbed. So this bile acid is excreted in the feces. So that means the bile acid which has to be absorbed and take cholesterol with this, it cannot be absorbed. So it is excreted outside. So basically बाबा जो है वो टैक्सी ड्राइवर को भगा के ले गया. So now cholesterol cannot be absorbed. Plus there is deficiency of bile acids. अब bile acid की जब deficiency हो गई, there is deficiency of bile acids, now the cholesterol of the liver, it will be consumed in forming bile acids. And when the cholesterol is consumed in forming bile acids, there will be less cholesterol in the liver. So what liver will do? It will induce the number of LDL receptors and they will take the cholesterol from the blood. So finally it will decrease in the blood. Okay, so revising, what is the mechanism of BABA, bile acid binding agents? BABA drugs, they bind to bile acids and excrete them. That lead to deficiency of bile acids in the blood, in the liver. So liver will start forming more bile acids. In that process, cholesterol is consumed. So now liver induce the number of LDL receptors on the liver so that they can take the cholesterol from the blood. Okay. Now the name of the drugs. What are the bile acid binding agents? The drugs are cholestyramine, cholestyramine, and cholecalciferol. And you can remember very easily the name of all start with chole. So like we use cholelithiasis, cholecystitis. So chole means bile. Clear? So these are bile acid binding agents. Now out of the three, first two drugs, they are not palatable. They do not come as tablet, they come as powders. And the powder is not easily palatable. So what we do, we need to dissolve the powder in the water, keep them for a long time, maybe 10-12 hours, and next morning we take. Yeah? On the other hand, colicibalam is present as a tablet which can be easily taken. Okay. Now, what is the advantage of bile acid binding agents? What is the advantage? The advantage is, if you can see that they come in the GIT and they go out in the GIT. They have never entered the blood. So they have never entered the blood, still they decrease the cholesterol. So when they have never entered the blood means they will have very lesser side effects. So the main advantage of these drugs is they are not absorbed. So they are drug of choice for dyslipidemia in pregnancy as well as drug of choice for dyslipidemia in children. So in pregnancy and children, BABA drugs are drug of choice. Okay. But the major disadvantage is bile acids normally has inhibitory effect on formation of triglycerides. So bile acids normally they inhibit the formation of triglycerides. So when we give BABA drugs, they will remove bile acids. So when bile acids are not there, this inhibitory effect will not be there. So that can result in hypertriglyceridemia. That is the major side effect of BABA drugs. They can cause hypertriglyceridemia. And if the triglyceride increase too much, what can happen? Yes, that can lead to pancreatitis. So hypertriglyceridemia can lead to pancreatitis. So due to risk of pancreatitis, bile acid binding agents are avoided in a patient with hypertriglyceridemia. Okay, so that is important about the BABA drugs. Okay. Then moving to number 5. Number 5 drug is niacin. And what is niacin? Niacin is nothing but normal vitamin B complex vitamin. It is vitamin B3. So advantage of niacin is it is easily available. It is cheap. And the another advantage is it has maximum HDL cholesterol increasing property. Apart from that, it can also decrease lipoprotein A, which no other anti-dyslipidemic drug can do. Even statins cannot do. So it can decrease lipoprotein A, which is highly atherogenic lipoprotein. It increase HDL cholesterol, which is maximum. Yeah? So niacin is cheaper also and having so many advantages. Yeah? But still, we do not use niacin commonly. The reason is side effects. And what are the side effects of niacin? So, niacin cause flushing and itching. Itching and flushing are the major side effects. Now my question is, will the person die from these side effects? Obviously not. But if a person know that after taking a tablet, I keep on scratching my body 24 hours, the person will stop taking that. So these side effects are not dangerous, but they are compliance limiting side effects. Most of the people will stop taking niacin because of these side effects. Then we do the study to find out why these are happening, and it has been found that they happen because niacin cause release of prostaglandin D2, and it is prostaglandin D2 which cause itching and flushing. So how to prevent this side effect? So safely we can prevent by giving aspirin. We know aspirin inhibit the formation of prostaglandin by inhibiting cyclooxygenase. Then we specifically formed a drug against niacin induced flushing, specific for this indication, and that drug is called as laropipirant. Laropipirant. Laropipirant, as the name tells, laropipirant says it is PR, means prostaglandin. Prostaglandin, which prostaglandin we are just discussing? D2. ANT means antagonist. So it is a prostaglandin D2 antagonist. And from the name you can also remember it can be given ORAL, means oral. So it is an oral prostaglandin D2 antagonist, so which is specifically used to prevent niacin induced flushing and itching. Okay, so that is important about the itching and flushing, which is compliance limiting side effect. Apart from this, niacin can cause hyperuricemia. Second very important side effect is it can cause hyperuricemia. MCQ is asked which dyslipidemic drug can cause hyperuricemia or gout. It is niacin. Third important side effect is in some people it can cause hepatotoxicity, but this is mainly seen in overdose. It can cause liver damage, and lastly it can cause insulin resistance. So it is avoided in diabetic patients. It can cause insulin resistance. Okay, so these are the important side effects of niacin. Okay, now these are the classical drugs we use in dyslipidemia, and quickly we can revise the most important point. Most important point is which drugs cause maximum reduction in LDL cholesterol? It is statins. Which drug cause maximum reduction of triglycerides? It is fibrates. And which drug cause maximum reduction or increase in HDL cholesterol? It is niacin. So these you need to remember. Okay. So now we can move to some of the new anti-dyslipidemic drugs. New drugs. So among the new drugs, first of all, we will discuss a very new target that is called as PCSK9. The full form of this is pre-protein converting subtilisin caxin type 9. PCSK9 is enough. Now what is this? We'll try to understand. Now this is our liver. This is blood. Now blood is having LDL cholesterol, bad cholesterol. So this LDL cholesterol is taken up by the receptors in the liver. There are LDL receptors on the surface of liver. So these LDL receptor, the function is to take up cholesterol. Now after the cholesterol bind to the LDL receptor, these LDL receptor will transfer the cholesterol inside. So after some time, the LDL receptor, they start resting. Now when they start resting, then these receptors, they are taken up by PCSK9. PCSK9 comes to this LDL receptor. He says that let's have a walk. So PCSK9 bind to the LDL receptors and take it for walk. The LDL receptor goes with it for walk. And what happens? It will take it while walking inside the lysosomes. So inside the lysosome, LDL receptor is sent. And what the lysosome will do? It will break the LDL receptors. So basically, PCSK9 help in breakdown of LDL receptors. And we want LDL receptors because they will take up the cholesterol from the blood. So if we inhibit PCSK9 by any method, then LDL receptor breakdown will stop. So that means there will be more number of LDL receptors. So they can take up more cholesterol from the blood. Okay? So the new strategy is to inhibit the PCSK9. Okay. So what are the drugs we have? The drugs which inhibit PCSK9 may be of two types. One, which inhibit the formation of PCSK9. And second, which inhibit the action of PCSK9. They stop the action, not the formation. Okay? The formation of PCSK9 is inhibited by a drug known as inclisiran. Inclisiran, the name says it is small interfering RNA. So inclisiran is nothing. It basically bind to RNA and stop the transcription of PCSK9. So PCSK9 will not be formed. Okay. On the other hand, we have some monoclonal antibodies which will bind to PCSK9 and stop the function. And these are alirocumab and evolocumab. Alirocumab and evolocumab, these are monoclonal antibodies which will stop the action of PCSK9. So all these drugs, they are indicated in homozygous hypercholesterolemia. Homozygous hypercholesterolemia. Okay. So that is about the first group of new drugs, the drugs which target PCSK9. Okay. Then we have another drug which is called as MTP inhibitor. MTP inhibitor. So first again we will try to understand what is MTP. This is our liver. Normally the cholesterol from the liver, it has to go into the blood. Clear? So liver will pack up the triglycerides inside a compound known as VLDL. So VLDL contain triglycerides. So this triglyceride is packed inside the VLDL with the help of a protein known as MTP. And the name of the MTP is microsomal triglyceride transport protein. So MTP is M for microsomal triglyceride transport protein. So basically it is transporting the triglyceride inside the VLDL. So if we inhibit this protein, VLDL will not be formed. So when VLDL is not formed, the LDL will not be formed. So there will be less cholesterol in the blood. Okay. The drug which do so is lomitepide. The name of the drug is lomitepide. The name says it is MTP inhibitor. Lomitepide is MTP inhibitor. Okay. Then we have another drug which is called as mipomersen. Mipomersen. Mipomersen is nothing. It is basically an antisense oligonucleotide. It is an antisense oligonucleotide against ApoB100. So basic concept here is what we can do, we can give a molecule similar to RNA. So normally RNA is forming ApoB100. Transcription of ApoB100 is obviously every substance is formed by some RNA. Transcription will occur. So the RNA which is forming ApoB100, we have made a molecule similar molecule to that. Antisense oligonucleotide. So it will bind to RNA at that place. So it will stop the formation of ApoB100. So and remember, any drug which is antisense oligonucleotide, their name will always end with arsen. Arsen. Arsen means RNA sense antisense nucleotide. So RNA antisense nucleotide will always end with arsen. Okay, so this is against ApoB100. So all the ApoB100 containing proteins like LDL etc. will not be formed. Okay, so this is also indicated in homozygous hypercholesterolemia. Okay, then we have another drug which is called as CETP inhibitor. CETP inhibitor. So again, first we'll try to understand. This is our liver. Normally, what happens is, we just discussed that VLDL, it is produced by the liver. So triglycerides are packed and that will form VLDL. So VLDL will go into the blood where it will be converted into the LDL. So this LDL can be deposited inside the tissues in the blood vessels leading to atherosclerosis. That is the main thing. But there is one substance where reverse cholesterol transport occur. That means from the tissues, from the blood, from the tissues, the cholesterol is taken up back into the liver. That is called as reverse cholesterol transport. So how that reverse cholesterol transport work is, liver will produce a compound known as nascent HDL. Nascent HDL. Now what this do? This will go inside the tissues and it will take up their cholesterol ester. So cholesterol ester which is present in the LDL and other substances, that is taken up from the blood, and nascent HDL is converted into mature HDL. Clear? So nascent HDL, the function is to take the cholesterol ester from the blood. So that cholesterol ester which has to deposit to cause atherosclerosis, that has been taken up. Now this HDL is coming toward liver. It has to bring this cholesterol ester toward liver. But on the way, On the way, these came LDL, VLDL, they came to this. They came to HDL and they say that now let's have a transport. Let's have a transport between us. We will exchange substances. So what we will exchange? They will say that give your cholesterol ester to us and take up triglyceride from us. So they are transporting the substances between them. So LDL or VLDL, they are taking the cholesterol ester from the HDL and giving it triglyceride. And this is done with the help of this enzyme known as cholesterol ester triglyceride transport protein. So cholesterol ester and triglyceride are transported, exchanged. So now the cholesterol ester which has to come in the liver is not able to come in the liver. So this will go into LDL and VLDL. So again, they will get deposited in the tissues. So we do not want this. So we have made a drug which can inhibit this transport, CETP inhibitor. So what CETP inhibitor will do? It will prevent this transport. So HDL will not give to them and come back to liver. Clear? So the drug which inhibits CETP is anacetrapib. Anacetrapib. It is a CETP inhibitor. So from the name you can remember cholesterol ester triglyceride transport protein inhibitor. So CETP inhibitor is anacetrapib. Okay. So now moving to the last drugs in the new category. This drug is called as avinacumab. Avinacumab. Now what is avinacumab? It's totally new strategy. It acts as a monoclonal antibody. But against what? Against a protein known as angiopoietin like 3 protein. It is a monoclonal antibody against a protein called as angiopoietin like 3 protein. Now what is the function of this protein? Angiopoietin like 3 protein, the function is to inhibit 2 enzymes. Function is to inhibit 2 enzymes. One is lipoprotein lipase and second is endothelial lipase. Lipoprotein lipase, we all know it is involved in metabolism of triglyceride. It is breaking triglycerides. Whereas endothelial lipase is mainly responsible for breakdown of HDL. So when we give monoclonal antibody, angiopoietin-like protein cannot work. So when it is not working, that means lipoprotein lipase and endothelial lipase cannot be broken. So that means there is increased activity of lipoprotein lipase and endothelial lipase. So when their activity increases means more triglyceride is broken. That means more HDL is broken. So the advantage is it can break the lipids. So it can decrease triglyceride, it can decrease LDL. So many substances can be decreased, but it also decrease HDL. So avinacumab decrease all the lipids including LDL, VLDL, triglyceride as well as HDL. So it also decrease HDL. Now what is special about avinacumab which is not present in other drugs? The special thing is its action is independent of LDL receptor density. Most of the other drugs, they will depend that the liver will take cholesterol. LDL receptor will increase in the liver, that will take cholesterol. But it has nothing to take with that. So LDL receptor may be less, may be more in the liver, it does not care. So it increase the uptake of the substances. It do not increase the uptake of the substances. It basically increase the metabolism of the substances. Yeah? So that is important about the avinacumab. Okay, so these are the important monoclonal antibodies or the new drugs for the dyslipidemia. Okay, so quickly we can revise what we have studied here. So we discussed initially about statins, the most important drugs. Statins, their mechanism we discussed, inhibit HMG CoA reductase. Then we discussed about statins, their major side effect is myopathy and interactions of statins with clarithromycin, itraconazole, gemfibrozil, we discussed that. So statins are the most important drugs. After the statins, we discussed azithromycin, which inhibit the intestinal absorption of cholesterol. Then we discussed the fibrate group of drugs which cause bile stones, gallstones, and fibrates also cause myopathy, gemfibrozil particularly. After that, we discussed BABA drugs, which are drug of choice for dyslipidemia and pregnancy and children. And lastly, we discussed niacin, which cause flushing due to prostaglandin D2. And then we discussed the new drugs, and particularly the latest one is avinacumab, whose action is independent of LDL receptor intensity. Okay, so these are the important points regarding the anti-dyslipidemic drugs. So quickly we can discuss some MCQs. Which of the following drugs should be avoided in a patient on rosuvastatin therapy? So with the statins, we should avoid three important drugs. We quickly revise. One is gemfibrozil, because it increases the risk of myopathy, and second are enzyme inhibitors, in particular clarithromycin and itraconazole. Okay, so we will see. So answer is clarithromycin here. Okay, enzyme inhibitor increase the level of statin that cause myopathy. Which of the following hypolipidemic drug act by inhibition of PCSK9? So we have two types, inclisiran, which inhibit formation, and evolocumab and alirocumab, they inhibit the action, the monoclonal antibody against PCSK9. Atorvastatin is a statin, we know. Ezetimibe inhibit absorption of cholesterol, and lomitepide is MTP inhibitor. Okay. Which anti-dyslipidemic drug cause gallstones? We discussed it is caused by fibrates. Fibrates can cause gallstones. Okay. So these are the important points regarding the anti-dyslipidemic drugs. My take-home message is failure is not the opposite of success. Mind it, failure is not the opposite of success. Failure is part of success. Yeah? So you fail, you try, you fail, you try, you fail, you try, and then you succeed. Yeah? So do not think that failure is opposite of success. So failure always give you some lesson. If you apply those lessons, you get the success. Thank you very much.